Hello, welcome to Adapt NCLEX, a place of knowledge packed and commonly tested content in NCLEX. Today, I want to focus on one of the important aspects of the cardiac pharmacology, and that is statins, cholesterol medication. Expect to get a question on this. So there's teaching, prioritization question, SATA question, and so we'll get to it quickly. And I hope you gain something from it. Once again, thank you for listening. Before we start, I would like to talk a little bit about how this medication work. It's very important that you know how it works. So cholesterol medication, statins, block synthesis of cholesterol in the liver, okay? And then one of the enzymes that they block is this. This is the key aspect of it. And I intentionally wrote it there. I know you don't need to know the name of the enzyme, but it's very good. We'll remember the side effect using this enzyme it blocks. So they block HMGCOA reductase inhibitor. I know it's a bunch of information, but it's very important. So that's all it does. It blocks it and it prevents synthesis of cholesterol components. One of them is LDL, that means low density lipoprotein, and this is the bad cholesterol. Then also decrease triglyceride, but increases HDL. So increase this, decrease that, and decrease that, then ineffectively it decreases total cholesterol. For your exams, they want you to know what levels you need to get. For HDL, you want the number to go up. And so for male, their cholesterol has to be greater than 50. HDL has to be greater than 50. For female, 45 is enough. So they need an HDL of 50 or 45. For LDL, you want it to be less than 100. Triglyceride, you want it to be less than 150. And total cholesterol, you want it to be less than 200. So the way to remember it is 50. Some people ignore the 45 in case they really want to be strict in terms of whether the male or female. But some people ignore and they use 50. They add another 50, you get 100. They add another 50, you get 150. They add another 50, you get what? 200. Then to remember which one it is, you just base on the alphabet. So H, L, and T. And this will be the total. This, then you put the total, another total. So HDL greater than 50, LDL less than, so it has to be less than, triglyceride has to be less than 150, and the total cholesterol less than. So this is the numbers you have to know: 50, 150, 50, 100, 150, and 200. You had 50 increments, and then you start with the H, the alphabet, H, L, T, and then T. One thing they can ask you is if somebody cholesterol is 250, okay, and I put them on statin, and it goes down to 220. That is okay. Okay, don't say, oh, it has not worked. It has dropped it, so it's working. It doesn't take a day to bring the cholesterol down to 200. So it takes a while for it to be normal. And therefore, we'll try and get this. If they give you a question, you have to say that it's working. The medication is working. The best therapeutic numbers are this. Greater than 50, 100, 150, and 200 less than. And therefore, even if it's coming down from 250 to 200, you have to pick an answer saying it's working. Patient has to continue what he's doing and exercise more and other things. So don't get fooled if they ask you that. But that's the what the numbers you have to know and which component of the numbers you have to know. Now, your test will be full of side effects. So they want you to know the side effect of the medication. Remember, I told you it's HMGCOA reductase inhibitor. That's enzyme. Where the side effect is also the same, HMG-CoA reductase inhibitor. So in order to remember, the H is liver injury, so hepatotoxicity. So it affects the liver. It also causes headache. The M, okay, the M is myopathy. So injury to the muscle, myopathy, that's musclepathy. Or it can be muscle weakness. Okay, so far as he has muscle. The G, they have GI side effect. So they have like nausea, diarrhea, and then they can pass a lot of gas. You can also put glucose, so increase your glucose, so you make your glucose go up. The C is catarrh, so high problem. But the serious part of the C is this one. I'll use another one, red. Is creatinine. We'll talk about all of them. Creatinine kinase. The R is another serious effect, is rhabdomyolysis. So rhabdo is a muscle breakdown. That's what it is. And lastly, the I is the same. You can say is increased glucose. This is the easy way for me to remember all the side effects for this medication because it's very important. So I take the enzyme and I said, the enzyme is the problem. So you are the side effect. HMG-CoA reductase inhibitor. So these are the side effects. So liver injury, headache, muscle problem, and GI problem, catarrh, and then rhabdo, and then increased glucose. So those are the side effects. There is a reason why all these things happen. And then the most important is the muscle. Okay. The medication, the statin, when you take it, okay, there's two forms. I don't have to go into details, but there's two forms. There is an acid form, and there's something we call the lactone form. This form, when you have more of this lactone form, it binds to the mitochondria. This is what make ATP. This is what make ATP. You know, ATP is the energy. So mitochondria is the energy house of the muscle. So if you can't make ATP, you get weak, no energy for the muscle start to break down. So breakdown of muscle. This is what causes the muscle fatigue, weakness, pain. So when the muscle break down, and that's what give you the issues with the myopathy. So the myopathy. If this progresses, it leads to what we call rhabdomyolysis. So that is the whole idea. That's why when these people are taking this medication, you have to be careful and follow them for this problem. So some of the question you should expect is, well, I forget something about the I. Now I remember. Okay. No, there's a A. I forget A here. HMG-CoA. Okay. HMG-CoA reductase. So there's a A there. Sorry. Now I remember. HMG-CoA. The A is avoid in pregnancy because it's teratogenic. So it's HMGCOA reductase inhibitor, so teratogenic. So for this one, because it's teratogenic, you tell them to use other birth control or contraception. So usually a barrier method. So let them use condom or diaphragm in addition to the birth control. And therefore, and then since it affects the liver injury, so these are all the teaching. We're going to use the teaching to answer questions. It affects the liver. You should know that if the medication affects the liver because it's broken down by the liver, they shouldn't take any medication that is also broken by the liver that affects the liver. So your teaching is don't take Tylenol, okay? Don't take any Tylenol for pain if you have any issue with that. What else? What also causes liver injury? That is common. You go to party, you get it all the time. In your weekend, you had some already. So ETOH. So no alcohol when you're taking statin because it causes liver injury and you're also going to have liver injury. Don't take Tylenol. It's going to cause liver injury. And then you should expect that they can ask you, somebody taking statin now as a liver injury or certain symptoms, you should be thinking, if it's causing liver injury, what are the symptoms of liver injury? Well, the LFTs, the liver function test, goes up. So liver function test increases, which is what? AST, ALT goes up. And they will become what? Jaundice. Because what? Bilirubin goes up. Okay. The liver make albumin. So, and if the liver is injured, it cannot make albumin. So albumin go down. Okay. The liver make clotting factors. If the liver in injury, it cannot make clotting factors. So your PT and INR, they increases. So these are the bilirubin increase. The only thing that goes down is the albumin. Sometimes platelet also go down, thrombocytopenia. And so these are the things you should be connecting so that you should in pharmacology, GI, everything is all connected. So you see these symptoms and say, oh, okay. And they can also branches and say, oh, join this. What happened to your urine? Well, you have tea-colored urine. What happened to your stool? You have clay-colored stool. What happened to your eyes? You have sclera ectorate. And then when they join this, they are African American. Where do you look at? Well, look at under their tongue, and it will be yellow. You see what I'm doing? I'm just connecting pharmacology all together for one medication because it causes liver injury. Now, the muscle, M. We talk about the muscle injury, right? Well, muscle, when you get injured, what do you think happened? It's a cell, okay? When muscle break down, muscle too is a protein. It releases content. One of them is myoglobin. This is the bad part, but we'll talk about it later. If the cell breaks down, it's going to release potassium. This is why when you have a burn wound, your potassium go up because the cells, we keep mostly our potassium inside the cell and our acid inside the cell. We keep them inside. So when you have a cell that bursts, potassium goes up. You release acid. H plus ion also goes up. So this is what you have. You can even increase your uric acid. You see what I'm doing? It's like tumolysis. I'm combining tumolysis together. So that's what is in the cells break down, the muscle cell breakdown, and you have this happening. This is bad, okay? This is what is really bad. So I will talk about this later, but let me focus on it. So you have high potassium, hyperkalemia. Well, they see what? Peak T waves. So I'm connecting everything that you should know. Peak T waves. Because of that, what would you do with this? Cardiac monitoring. And somebody have peak T waves from hyperkalemia, you have to protect their heart. What kind of medication you give them? Calcium gluconate. So you have to connect everything. Is H plus ion has increased? What kind of acid-base problem you think? You making more acid, so this is what? Metabolic acidosis. This will come in handy when we have to treat this patient with muscle problem, which they develop myomyelitis. And so this is all going to be connected together, as you can see. And so that's the issue with the myopathy. The GI symptoms, it's not that bad. It's not a bad symptoms. I'm not going to worry about it. So if they give me a bunch of symptoms, there's only two I need to worry about: myopathy and rhabdo. Those are the two for this medication. I don't worry too much about the liver injury. If there's myopathy, I'll pick it that one before the liver. Okay, and that's you being sharp about it. GI symptoms, diarrhea, those one is not important. Cataract is not, of course. Yeah, if there's a pregnant lady, is important, but in your test, prioritization, you got to prioritize. No, one, what is going to be bad is rhabdo or myopathy before even liver injury. So that's how you do your prioritization. You being sharp about it. So we already started talking about it. So you have the cell potassium here, H plus here, and the muscle of the cell breakdown. Okay, so it break down a little bit like I messed it up. So cell in this area break down, and all the potassium get released, the H plus get released, and the myoglobin also get released. This causes hyperkalemia. This causes metabolic acidosis. But the big problem is myoglobin. This is protein. Your body cannot break it down. So it forms clots. So if this is your blood vessel, you form clot, myoglobin, they get to the kidney, and the kidney get into trouble. They get into the kidney, and it clog the kidney. And so you have like renal failure. This is why this is very dangerous. The product of the muscle breakdown, it go to the liver, no, the kidney, and they clog the kidney. It's like I would say debris that clog the kidney, and then it causes acute tuberculosis. Basically, these are fancy words. Basically, injury to the liver, to the kidney. So kidney injury, so they go into renal failure. What do you think when these people try to pee? Well, their pee, it will look like a myoglobin, which is almost red, like a muscle. So they will have dark urine. Some of them may look red. Okay. And because it's in renal failure, anybody in renal failure, they have low urine output, really concentrated. And this is what you expect in rhabdo. All this breakdown of muscle, releases of its content, forming myoglobin, going to the kidney and blocking it. It's all the consequences of rhabdomyolysis. So what you a sign you will see is the creatinine kinase. This is the enzyme that is in the muscle. When the muscle break down, these enzymes is also released in addition to the myoglobin. And then when it's more than 5,000, anything more than 5,000, that means patient has developed myoglobin. So there's increase in creatinine kinase more than usual. So greater than 5,000 has developed myoglobin. If they give you a patient with high level of CK, which is creatinine kinase 3,000, 4,000, 5,000. I'll pick this patient because it's a priority patient. They're going to develop rhabdomyolysis. That means muscle is a sign of muscle breakdown. Sign of muscle breakdown is creatinine kinase, and a high level, like over 5,000, is definitely a rhabdomyolysis. So look for CK. It tells you there's myopathy, muscle breakdown, and look for rhabdo. If you see dark urine, signs of renal failure and decreased urine output. Signs of renal failure, you expect their creatinine to go up, their BUN to go up, and their GFR goes down. So that's a sign of rhabdomyolysis. So how do you treat this? Based on the pathophysiology we've talked about, how would you treat it? Well, you have something clogging the vessel. Okay, it's clogging this muscle, it's clogging the vessel. Then you go to the kidney, okay, you go to the kidney and clog the kidney too. It clog the kidney. So how can I relieve the clog? Where I give them fluid, bunch of fluid, IV fluid, IV fluid, IV fluid. That's your number one. Keep on hydrating them. This is not the one you give them 100 cc, just give them like 200 cc per hour. You bolus them and flush the tube and allow all this to go away so that you dilute them and they will all be able to get rid of everything as much as possible. I told you the kind of acid-base problem they're going to have. They're going to have metabolic acidosis. So how can you neutralize the acid? Give them a base. So they get a bicarbonate. So they get a bicarbonate drip. So they get bicarbonate, sodium bicarbonate to help dilute the acid. So the fluid they get, if they get normal saline, they will get sodium bicarbonate in addition so that they can dilute the fluid then and help with the acidosis, basically to break it down. Okay, it basically neutralize it and help with that. And so that's what happened with that treatment. So they get IV fluid, they get sodium bicarb. You have to take care of the potassium, and that means you send them to the ICU, monitor cardiac monitoring, making sure you controlling their K. Usually the K will neutralize quickly when you give them a lot of fluid. The number one problem is the fluid. As soon as you give them fluid, all this thing will begin to correct itself, the bicarb and potassium. In case the potassium never get corrected, you know how to control and treat potassium. But I just want to quickly give you some quick tips about how to control potassium. Well, first, you got to get rid of it. So they get laces, so furosemide. They have to protect the heart first. So they get calcium gluconate, okay, 1 gram of calcium gluconate. Then you get rid of it through the laces. Then you push it inside the cell. So they get insulin and glucose. So insulin and glucose will push the potassium inside the cell. The laces will let you pee it out. The calcium gluconate will protect your heart. And then there's albuterol. Albuterol also push the potassium inside the cell. Some people forget about it. Albuterol will put inside the cell. Then they get K-acylate. K-acylate will let you poop it out. If that doesn't help, they get dialysis. So this is all the things in a SATA form. How do you control hyperkalemia, calcium gluconate to protect it, that laces to let furosemide to let them pee it out. Insulin and glucose. You need insulin and glucose to push the insulin, the potassium inside the cell. Albuterol to push it inside the cell. KSLA to bind it in the GI tract, and dialysis to remove it out of it. So that's the treatment of rhabdomyolysis. IV fluid, IV fluid, IV fluid, and then sodium bicarb to dilute the metabolic acidosis. So your teaching is to prevent all this, okay? Education as the next. Number one, okay, if you have muscle weakness, if you have muscle pain, please call as soon as possible. You don't want to get them to rhabdo. So any patient, they give you 4 patients, and they say, who do you see first? And you see somebody on statin with weakness or muscle pain, please choose the answer. Unless there is an airway answer there. If there is none, this patient is going, his pain, if you look at my B sharp, the pain is having, it's a live limb eyesight kind of pain. So he's going to lose his limb, he's going to lose his life because his kidney will go in failure. So there's 2 L's. You need to see this patient. And if they give you creatinine kinase 10 times the normal, so like over 5,000, that's another sign. They may not tell you it's rhabdo. They will tell you certain things, muscle pain, CK very high, or they have urine that is dark. When they are on statin, that is your clue. So go see the patient or pick that patient as number 1. So let's try some questions as usual. So the nurse should teach the client to report this immediately to the healthcare provider, okay? Prioritization question. You're going to be what? Be sharp, not expected. Watch my prioritization video. This is the key for all prioritization questions. A client with a diagnosis of familial hypercholesterolemia was prescribed atorvastatin. So he was prescribed statin. Which one is a priority? Okay. What symptoms? Nausea. Well, the key is HMGCOA reductase inhibitor. I see GI symptoms is not a problem. The problem is the C, right? And the R, C and R. So this is not a problem. Polyuria is because this may be coming from the glucose. So they have hyperglycemia, they pee a lot, like diabetics. So this is not a problem. Diarrhea, GI problem. This is not a problem. Muscle cramp, yes, my boy is in trouble. Is red. This is red. So we got to pick this one. Otherwise, he go into rhabdo. So that's the way the question will look like. Same thing. The nurse should notify the HCP immediately with which assessment finding. A client with the diagnosis, the same questions, but I changed some of the things. Familial hypercholesterolemia was prescribed the same medication, atorvastatin. The nurse should notify the healthcare provider. These are several ways for them to trick you. The same thing, you're on statin, which is a priority finding. Once again, 2 priority is myopathy and rhabdo. And you're looking for CK that is high, that's all, or peeing, dark urine. So AST is 660. It's a little bit high, but not too high, but that means there's liver issue we will let them back off their medication a little bit, but that's not bad. BUN of 15, this is normal. CK over 10,000, yeah, that's rhabdo. So Y count of 13, don't get full. I intentionally put 13 there. It's not a problem because there's muscle inflammation. The Y count goes down up a little bit. So this is not a problem. I don't care about it. CK is rhabdo. Your answer is in HMGCOA reductase inhibitor, and C and R is my problem. I see a C, I'm picking it. That's all. That's how you do prioritization. You know which one is going to kill them, which one is more important, and you stick with it. Same thing. And then you expect which prescription from HCP. A client with diagnosis of the same question, hypercholesteremia, was prescribed the same medication, atorvastatin. The patient present with dark urine and severe muscle pain. So I'll write my keywords. Is on statin, dark urine, muscle pain. So statin, well, what happens when statins cause dark urine and muscle pain? That is rhabdo. So what treatment? I'm looking for treatment. Cardiac monitoring. Yeah, potassium goes up from the rhabdo. So we go to cardiac monitoring. Normal ceiling at 200. Yeah, treatment for rhabdo, number one is IV fluid. Prescription for serial CK. Yeah, if it's in rhabdo, I expect the CK to be more than 5,000, and you have to check it so that you can see that it's going down. When it starts going down, that means the rhabdo is resolving, is getting better, and then your management is working. So yeah. Strict I&O. Yeah, I want to know if the patient is peeing because he go into acute renal failure. Yes. Sodium bicarb. Yeah, they develop metabolic acidosis. So I have to dilute that by giving them bicarbonate. So sometimes such a question, I intentionally put there. All of them are right. Sometimes only you have one or two. So don't be afraid, but don't choose if you know it's not right. So this is everything about statin. There shouldn't be any question that beats you. Once again, thank you for coming. Thank you for listening. If you like this, please visit my channel as I develop it, and then like it on YouTube and put some comments. Take care of yourself, and once again, keep charging. Success is yours.